Good afternoon. My name is Brooke Jeffrey. I'm Professor of Radiology and Chief of Abdominal Imaging at Stanford University. And this afternoon I'm going to talk to you about ultrasound evaluation of cervical lymph nodes, emphasizing criteria for normal and abnormal, and try to provide you with some tips on how to perform ultrasound-guided FNA of these nodes. This afternoon, my lecture is going to focus on the ultrasound evaluation of cervical lymph nodes. And what I'd like to do along the way is to review the indications and ultrasound technique for evaluating these nodes, to emphasize certain anatomic landmarks for distribution of nodes, and really to focus on the criteria that we'll use for distinguishing normal from abnormal, and discuss role and technique of ultrasound-guided FNA of these cervical lymph nodes. For the most part, the main evaluation of cervical lymphadenopathy relates to head and neck oncology. And I think it's fair to say that sonography has a relatively limited role in staging most head and neck cancers. And current state-of-the-art CT, MR, and PET are used primarily for many head and neck carcinomas, many of which are squamous cell carcinomas. The exception to this is in the patient with thyroid cancer. And here sonography is equal or superior to CT and MR in defining many of the characteristics of nodal disease. And of course, once an abnormal lymph node is found with CT or MR or PET, it's much easier, as we'll see, to be able to biopsy that lymph node with sonographic guidance. There has been some data to suggest that in comparing ultrasound with CT, that they're essentially of equal accuracy with papillary carcinoma, but ultrasound has the distinct advantage of low cost, lack of radiation, lack of contrast agents, and so it has become the technique of choice, particularly in the patient with papillary cancer in which we suspect there is involvement of cervical lymph nodes. It should also be pointed out that there's certain anatomic regions, such as the thoracic inlet, that are somewhat tricky to evaluate with CT, and this is a patient who had CT of head and neck read as a negative for lymphadenopathy. It's only in retrospect that we can see soft tissue fullness in the thoracic inlet. Now, the cervical lymphadenopathy is much easier to see with ultrasound. And of course, if we can identify things with sonography, we can then go on to biopsy. And this is an example of a recurrence of non-Hodgkin lymphoma that was much better detected with with ultrasound rather than CT. The point to be made is that there's certain anatomic areas like the thoracic inlet where ultrasound excels. Now, in terms of technique, we want to use the highest frequency transducer that will give us adequate penetration in the neck. And we say that for several reasons. Number one is to improve the spatial resolution, but number two is to improve the color Doppler sensitivity. And we'll be seeing that most clinically relevant lymphadenopathy is going to be along the jugular vein, what's called the lateral chain. And once we identify a potentially abnormal node with grayscale, we're going to go on to use color Doppler to further characterize that lymph node. So let's look at the key anatomic spaces in the neck that we're going to be looking at. And here you can see the submental and submandibular spaces. And then along the jugular chain, we have the upper, middle, and lower cervical chain, and then along the posterior triangle. Now, these spaces correlate to anatomic levels, and you'll hear head and neck surgeons refer to a level 2 lymph node. Well, that's right around the submandibular gland. In the mid portion of the neck, that's level 3, the lower portion 4, and posterior triangle 5, etc. And you'll also hear of the term the central compartment, and these relate to nodes in the bed of the thyroid that are removed at the time of total thyroidectomy. So that's an important anatomic area as well. And we'll talk about recurrence in the central compartment for thyroid cancer. Now, in beginning our anatomic search for lymph nodes, we find it very easy to do a survey along the jugular vein to detect lymphadenopathy. And we can see here that levels 2, 3, and 4 really are the most prevalent sites that we want to investigate. There rarely are some metastases in the submental area, rarely in the posterior triangle, but levels 2, 3, and 4 really are the key anatomic areas. In terms of characterization of cervical lymph nodes, we want to look at 4 parameters: their size, their morphology, echogenicity, and of course the color Doppler characteristics. Now, in terms of normal lymph nodes, again, it's important to recognize how the literature has designated by convention the measurement of nodes is in the short axis. This is very critical because the long axis really is not a relevant measurement. In general, most normal neck nodes are elongated or oval, and they're not round. They tend to be hypoechoic, and they may or may not have an echogenic hilum, which may relate to fat in the central portion of the lymph node, or it may be related to acoustic reflectivity of the central lymphatics. Now, with color Doppler, normal neck nodes rarely have much color, but when they do, it always is in a pattern of central arborization, and that'll be very important as we distinguish abnormal neck nodes. Morphology and echogenicity always trump size in determining if the node is abnormal. It's a very important observation. Now, here are examples of classically normal neck nodes. This one has a clearly defined echogenic hilum. It's elongated. It has minimal flow coming in a central pattern. Again, I want to make the point that only the short axis of the node is a relevant measurement. And you do not want to be calling your clinician with this very elongated node and call this a 2.5 centimeter lymph node. It's really only a 4 millimeter node because the short axis is the only relevant measurement. And here are some other examples of normal elongated neck nodes. And by way of contrast, here's an abnormal rounded node that had metastatic thyroid cancer immediately adjacent to a normal elongated node. So morphology is often a key first finding for abnormal nodes. Now, is it the case that all elongated neck nodes are normal? No, because if we see abnormal echogenicity and abnormal color findings, that will trump the elongated morphology. Here's an example of papillary carcinoma involving the neck nodes, which has microcalcifications and cystic change. So we can see on the left, and then on the right in the color image, instead of a central pattern of arborization, now we have a peripheral flow pattern. So elongated lymph nodes may occasionally show other findings that clearly indicate involvement with disease. Here's another elongated lymph node where there are clearly evident microcalcifications. Now, microcalcifications are not, strictly speaking, specific for papillary cancer, although in the post-thyroidectomy patient, we rarely encounter anything else. But depending upon your patient population, cervical tuberculosis with granuloma formation may cause microcalcifications again, but that's a very rare phenomena indeed. Now, reactive lymph nodes tend to be slightly enlarged, but they're, for the most part, elongated, and they have slightly increased flow, but again, it has a normal central arborization pattern. The echogenicity is usually always normal, and these were lymph nodes that were biopsied and proven to be reactive lymph nodes in a patient who had pharyngitis. And again, see the elongated, slightly plump, if you will, morphology. Again, on color flow, there's a central pattern of arborization. And some reactive lymph nodes can be quite large, and we can be clearly confident that they're reactive, again, by the elongated configuration, the preservation of the echogenic fatty hilum, and the central flow. Abnormal neck nodes tend to be rounded, and they tend to have borders that are often irregular. That's not specific for tumors. Sometimes other infectious diseases, such as TB adenitis, may cause the borders to be irregular. Frequently, there's loss of the echogenic hilum, and often there are morphologic changes that we can see with grayscale that tell us that node is abnormal. We've seen some examples already with internal cystic change, calcification, or increased echogenicity. The color Doppler flow shows a wide spectrum of abnormalities, but basically it's some deviation from the pattern of normal central arborization. So let's look at some abnormal nodes and some examples of rounded morphology with lobulated irregular shapes. And here's an example of a patient with metastatic breast cancer. These are rounded nodes, and instead of having the central flow, peripheral flow. Here is a patient that has metastatic papillary cancer. Notice how irregularly marginated the node is with subtle but demonstrable cystic change within the node and markedly increased flow pattern, not that we would associate it with a normal flow pattern. These nodes, compared to the adjacent strap muscles, show increased echogenicity, and they have a rounded morphology. And these two are involved with papillary carcinoma. Here's another patient with rounded morphologic nodes, and this was supraclavicular lymphadenopathy related to lung cancer. Other rounded nodes, we can see here with abnormal flow patterns and very rounded morphology related to lymphoma. And again, another case with rounded morphology, abnormal flow related to breast cancer. When we see marked nodularity or lobulation of the contour of the node, we have to consider that there's extracapsular invasion. That's particularly common with a lymph node such as squamous cell carcinoma. Here's such an example. And we can see in the correlative MRI, the node is invading right into the muscle. The reason why that's important, as the surgeon goes to extract the node, forewarned that this is locally invasive, the head and neck surgeon will also take a surrounding cuff of muscle to get negative margins. So we can, when there's marked nodularity, often suggest that there is extracapsular invasion. Here's another example of abnormal morphology with irregular contours, and this too had extracapsular invasion. Notice the multiple areas of microcalcifications. So one teaching point to make about papillary carcinoma is that echogenicity is often the key finding, whether it's cystic areas or microcalcifications or increased echogenicity. So that trumps just about every other finding. Now, the reason that sonography has emerged as the technique of choice to evaluate patients with papillary carcinoma is the ability with high-resolution transducers now to see these subtle microcalcifications, subtle areas of cystic change, and contour irregularity. And in addition to the features we've already mentioned, such as loss of the normal echogenic hilum and increased nodal echogenicity, these are very specific features. And when we look at the data on this, it's quite impressive. Here's an example of 198 nodes in 112 patients, published in JUM by Rosario et al. And look at these specificities. If there's internal cystic change, 100% specificity. Calcification, again, 100% specificity. So really a very specific technique for evaluation of cervical lymphadenopathy. Now, one of the reasons that ultrasound is so helpful in terms of guiding biopsy is we can define the areas that are going to be most fruitful to direct our needle. And here we can see the cystic change in the upper pole of this lymph node telling us it's a metastatic node involved with papillary. But of course, we wouldn't want to biopsy that area. We would want to direct our needle to the solid vascularized portion. Similarly, in this patient with extensive intranodal cystic change, you do not want to be aspirating simply the fluid components. You want to direct your needle towards the central area that has multiple calcifications. Similarly, in this patient, the mid and lower pole has cystic change, the upper pole is more solid, and here we can see examples of increased echogenicity, cystic change in a very abnormal lymph node. Another example where there is more focal cystic change, again, we would want to direct our needle away from that. Now, occasionally in patients that have suppurative lymphadenitis, you will have abscess formation. And this was such a patient who had a chronic infected lymph node, and we aspirated this and sent it for culture and sensitivity. So cystic change in the lymph node may be related to infection in the appropriate clinical setting. Generally in the patients who are post-thyroidectomy and for papillary cancer, that's not a clinical concern. Here's a really nice example of increased echogenicity, markedly abnormal node. We can see their focal microcalcifications. And here's a more confluent area of calcification. So sometimes these calcifications sort of aggregate and may cause acoustic shadowing. So any calcification at all is always circumspect and always very suspicious for metastatic papillary cancer, whether it shadows or not. Some of the nodes are dramatically hypervascular, and here is a patient. Actually, the thyroid gland was completely normal in this individual, and a thyroidectomy had only a 2 millimeter carcinoma, yet presented with a neck node. See how strikingly echogenic it is and how strikingly vascular this is. We'll make the point when we talk about biopsying highly vascular lymph nodes that we have to use a capillary technique rather than a suction technique, or we'll just get blood. So in papillary carcinoma, the echogenicity of metastatic nodes is often different than the primary cancer. Most primary cancers of the thyroid tend to be hypoechoic. And here's an example of a lesion that's taller than wide. It has discrete margins, has increased flow, typical thyroid cancer. Here's another patient, taller than wide, hypoechoic thyroid cancer. But the lymph node is markedly different than the primary tumor. Notice that the lymph node is now echogenic, and despite the fact that no microcalcifications were seen in the primary tumor, it's just loaded with microcalcifications. So don't require that the neck nodes look the same as the primary. Here's a patient with a primary cancer in the thyroid, and just immediately adjacent to it, the cystic nodal mets has an extensive cystic change. So again, there's often quite a discrepancy in the echogenic appearance of nodes versus primary cancer. Here's a solid papillary carcinoma that has calcification and yet extensive cystic change within the nodal mets. Now, we've made the point that the normal Doppler flow pattern is a central pattern that's often very minimal in normal patients. And here you can see increased echogenicity. Notice how rounded the nodes are compared to the strap muscles. These nodes have increased echogenicity and have really a striking degree of peripheral flow. So here's an example where the color Doppler and the morphology and echogenicity all point to abnormal lymphadenopathy. And these are nodes that are just stacked up each other in level 3 along the jugular vein. And here we can see these hypervascular lymph nodes on a contrast-enhanced coronal and sagittal CT, and you can see how vascular they are. Notice again on the color Doppler examination of these two patients, some of these nodes have real spotty areas of increased vascularity. You will not see increased flow in cystic areas within the node, and so again we want to direct our needle to the solid vascularized portion of the lymph node. Here's just another patient with chaotic flow pattern. It's often quite hard to give morphologic descriptors of the flow patterns. It's just that they look very different than the very subtle central pattern. So any deviation from that central pattern should be considered abnormal. So when biopsying these nodes, direct the needle away from cystic areas and towards areas of visible blood vessels. However, if there's a lot of vascularity within the lymph node, we want to first use an aspiration technique. This is an example of a patient who has a very large lymph node in the right neck, microcalcifications. This was biopsied at an outside institution several times with no adequate cytology. And here we can see the reason for that is that the area of the node that shows dramatic increased flow is quite vascular, and we would only get blood. So we directed our needle away from that node. In this case, we could use a suction technique because we're going into solid tissue, but it wasn't richly vascularized. It's sort of a window of decreased vascularity. And here you can see on the cytologic specimen the sort of papillary frond-like nature of papillary carcinoma. Now, when we're referred patients with head and neck cancers, particularly when it's squamous cell carcinoma, often these nodes have a striking degree of central necrosis. And here, head and neck gadolinium MRI, notice that on the right, one of them is homogeneously enhancing, but the more anterior node has extensive cystic change. So with squamous cell carcinoma, because of the cystic appearance, and here's just another example on now a T2-weighted sequence with fat suppression, how cystic these nodes can be because of the extensive central necrosis. So when presented with a patient either with squamous cell or with papillary carcinoma that has extensive internal cystic change, the key here in terms of making the diagnosis is to direct the needle to the solid peripheral tissue. And so you want to go towards the periphery and not centrally. And here's another example comparing the ultrasound to the contrast-enhanced MR. And it's often very good to be looking at the MR at the time of biopsy to sort of map out in your mind exactly where you're going to put the needle. And here's another example of extensive cystic necrosis, but you can see there's a little portion of solid tissue more medially, and that's where you need to biopsy. And in general, you will get much more cellularity in biopsying the peripheral portion of a lymph node. And here's such an example, previously biopsied at an outside institution, negative results. And you can see, although the node looks uniform, there was central necrosis, and we can't always see it because we don't have contrast agents as we do in head and neck CT and MR. And here's the example of showing how the needle is on the periphery. Now, if you're presented with a node that's got extensive cystic change and one that's very vascular, and to biopsy these lymph nodes, you need to take a different approach. We can be successful biopsying cystic nodes if we direct the needle in the solid portion, and we would use the suction technique because this tends, depending on the vascularity, if this wasn't particularly vascular. The point being is we would not want to direct our needle in the cystic portion of the node. Similarly, these hypervascular, these are small nodes, but they were positive. They can be biopsied successfully, and the point being is we want to use a capillary technique, not a suction technique. We'll just get blood if we use a lot of suction. So it is possible to do FNA of less vascular nodes, and we have to know when to do suction versus capillary, and it really depends on the degree of vascularity. Let's talk a little bit about the post-thyroidectomy patient and using ultrasound to look for recurrence, either at nodal sites or in the thyroid bed. And if we're talking about the thyroid bed, we want to pay strict attention to any hypoechoic tissue, particularly if it's vascular. And biopsy should be considered for lesions that are 5 millimeters or greater. And in general, they tend to be hypoechoic. Occasionally you see microcalcifications, and a lot of them we found have increased flow. So here's a typical patient that has recurrent papillary carcinoma within the thyroid bed, and here you can see we're directing our needle into this recurrent mass, and this is proven to be papillary carcinoma in the thyroid bed. And again, we can see another hypoechoic nodule in the echogenic fibrofatty tissue. If we can see it, we can direct our needle into it. And here's an example of actually going to the operating room and performing an intraoperative ultrasound to biopsy this lymph node and to guide the surgeon intraoperatively. The color can be very helpful in looking for a variety of thyroid bed recurrences. And here's an example of very subtle increased thickening of the soft tissues around the trachea. We can see subtle widening of the trachea here. And with increased flow, we can see that there is a more clearly evident hypoechoic soft tissue mass that is really richly vascularized. And this is an extensive recurrence that's invading the trachea. And the hallmark is hypoechoic tissue that's richly vascularized.